Thank you, Carlin, and thank you to all the members of the team, Carlin, and the rest of the team for the opportunity to come up here today. Good to see a few familiar faces in the crowd, and I'm hoping that we can make today's talk somewhat fun. It's going to be quite interactive, so get your little clickers out and we'll get started. So first of all, I have no disclosures that are relevant to this particular talk. And our format today is going to be some case reviews. And as Colin says, hopefully that's going to pull together some of the information that you've been absorbing this last day or two. And you're going to participate and tell me what we're going to do. And the answer is always surgery, because we're surgeons, right? So you're just going to answer surgery. And then we'll have a discussion about it. So we'll start out with the knee. And this is a patient of mine, and he actually played for the Mustangs, which was the team that should have beaten Dr. Ma's team and be at the state championships. They've been before, but we didn't make it this year. And he was their star football player and twisted his knee on the field, came off, came into the office the next day. His exam showed a swollen knee. He was stable. His anterior draw, Lockman, pivot shifts were all negative, but he clearly had a very distinctively tender lateral joint line and a positive McMurray's. X-rays, as we would probably expect, were negative. And when we looked at his MRI, there's a clear problem here with the lateral meniscus. The medial meniscus, posterior horn here looks good, but we're missing some lateral meniscus there. And on the sagittal, there's a piece of meniscus where it shouldn't really be. It's sort of flipped under and trying to go down the back there. So our diagnosis here pretty clear. This is a lateral meniscus tear. And when we decide what we're going to do for this patient, and any of our patients, of course, we're going to look at various factors. And the ones that I typically look at most actively are going to be the patient's age, their physiological age. We'll talk about physiological age more than chronological age. Their activity level, that's both what they're doing and what they want to do. And when we're looking at a meniscus tear specifically, we want to know what type of tear. We've seen this one as a flipped tear of the lateral meniscus. We want to know what the underlying condition of the knee is. Ben Ma talked about those worn-out knees. We're going to be a little less aggressive about treating a badly arthritic knee than we are in a 17-year-old. And what other associated injuries? Well, our decision is based on not just what that meniscus looks like, but what that ACL looks like, what that MCL looks like. So, what is the audience going to tell me to do on this patient? Are we going to do physical therapy and see how he does? Completely shut him down for a while? Stem cells, we heard about, expensive. Maybe that's the right answer. Or how about surgery? Boom. Okay. So, the majority of you are helping me out here by recommending surgery. Some of you think that this is something conservative, and there may be a place for a conservative treatment in this situation, but I think that the real answer here is surgery, and the reasoning goes back to our considerations. This is a young patient. He had an acute traumatic injury. It's an unstable tear. It's flipped. It's only going to get in the way. It's mechanical. The underlying condition of the knee is excellent. It's pristine. This is a young patient. He's got a perfect knee other than his meniscus, and he has no other associated injuries. He does not have an ACL injury, associated with this. So, for this kid, we definitely did surgery, and he did well. Got back to playing, repaired that meniscus. Long recovery with the repair, but got back to playing, and everything is fine. Okay, so let's move on to something a little bit more complicated. 46-year-old, still young in my book. Had a history of a prior ACL reconstruction, did well 10 years ago. Now it's got progressive medial pain. is, reasonably active, but not really an athlete of the sort that we just saw, and has no significant instability. So his ACL did well. He's nice and stable in his knee. And he comes in and he's got an effusion there. It's small, but his knee still is stable. And he's got tenderness in the medial and the lateral joint lines. His McMurray's and Thessaly's on both sides are positive. So we get an x-ray, and you can see that he's got a big screw in here, and he's got some early arthritis of the notch here. And if we look at the medial and lateral joint lines, they're somewhat preserved. He hasn't fallen into complete arthritis yet. But if you look closely, you'll see there's some chondrocalcinosis in those joint lines. So there's some degeneration. And his patellofemoral joint, his knee's sort of midway wearing out at this point. It's still, like I said, there's still joint space and it looks reasonably good. And we get an MRI and the radiologist report comes back and says, okay, he's got medial and lateral meniscus tears. So, same set of considerations again. What is the patient's age and their activity level? Somewhat older patient here and, not moderately active, not a high-level athlete. The types of tears, these are more degenerative type tears. And the underlying condition of the knee, it's got some wear and tear on it. And, associated injuries, no, his ACL is good. So, what are we going to do? Physical therapy, we do use braces quite a bit with patients. We've got a series of injections we can use, or of course we can do surgery. Okay, so a small percentage of you wanted me to go straight to surgery, and I think maybe when I came out into practice now, that's 20 years ago, anytime we got a radiologist report that said meniscus tear, lateral, medial, or both, we were booking that patient for surgery. We were rushing to surgery to fix that patient's knee because they had meniscus tears. Those were clearly a problem. Well, we've discovered over time that actually physical therapy is probably exactly where we want to be for the first choice. An unloader brace is a good idea in many of these cases, but this is bilateral, or at least medial and lateral. So unloader really puts you on one side or the other. So if it was all medial-sided disease, a medial unloader brace would be a good choice. And injections and cortisone, in my practice, I think we certainly try with the physical therapy first, then go to the cortisone and move on from there. And I think this has changed over time. There may be an older generation of orthopedic surgeons in your communities that still operate on these as the first-line choice. But starting about 10 years ago, studies started to really come out in the bigger journals showing that surgery versus physical therapy for these degenerative tears really has no significant difference, and these patients can be well treated with with physical therapy. And even if you do sham surgery on these patients, they don't get, as Dr. Ma mentioned, they don't get much better anyway. So we really have shied away from these degenerative tears being surgical things. In my practice, we definitely try conservative management first for these patients. Most of them will get better with physical therapy and or a combination of injections, activity modifications. And we have started using some PRP. Again, it's a little bit experimental, but at this time, certainly from a data point of view, but there's a lot of patient demand for it. So I think we're becoming more active in using PRP. I think there's going to be a place for it. It's not fully defined. And we do end up doing surgery on some of these patients, but to make the point clear, degenerative tears, it's usually a non-surgical treatment to start with. Okay, so let's keep going. 61-year-old, a little bit older now. This is another knee problem. This gentleman was doing fine, but stepped off a ladder and twisted their knee, and now comes in with medial pain. So not all my patients have medial meniscus tears, but a lot of them do. But the examination here shows that some mild swelling, tenderness in the medial joint line, and a positive McMurray's and Thessaly test. So we presented a patient that's very young, straight to surgery, one that is a little older, but conservative treatment. This patient has x-rays that look like this. So this is a 61-year-old. There's good joint space on both these knees. I hope at 61 my knees look like this. We've got an MRI here, and here we have a small tear. It's sort of a oblique tear in the posterior horn here, and it's out towards where the blood supply is pretty good in the meniscus. You can see it again on the sagittal. This is not a large tear. There's not a big flap component. There's not a bucket handle here. But it is an acute tear in an older patient who's actually doing quite well in terms of their physiological condition of the knee. So again, we look at the considerations. A bit older, reasonably active. The type of tear is a small, we would consider that probably a stable type tear. The underlying condition of the knee is good, and no significant associated injuries. So what are we going to do with this patient? There's a place for physical therapy. We could unload that medial compartment, get that pressure off there. We could use PRP or even stem cells to help that grow. Or the ever-present option of surgery. Okay, so people here like physical therapy, and I think that's a very good idea. This is an older patient. It's not an unstable tear with a large bucket handle component. I think this is the type of patient which we would have some consideration for surgery, but lean more towards conservative management. I don't think you could fully criticize the option for surgery here. I think it would be a choice. But in our practice, certainly we were more conservative and go with conservative treatment, which is what this patient underwent. Had physical therapy and even got a cortisone injection, a fair amount of time to declare which way this was going to go, but he continued to have pain, unable to play his golf and tennis. So what do we do next? We've tried the physical therapy. You could always try more PT. An unloaded brace, again is not an unreasonable option to try and unload and see if that helps. PRP and stem cells, surgery. Okay, so surgery. And in fact, that's what we did here. You can see that this is a macerated meniscus. It looks worse than it did on the MRI. Those people who chose surgery in the first place might have been that was the correct choice, but I think that we usually want to give these patients a trial of conservative management first. This patient's gone on to do great, and it just points out that even in an older patient, 61, there's still a role for meniscus surgery. There's a lot of bad press about doing meniscus surgery, but it really focuses on those degenerative patients. This is an acute tear. This is a patient whose cartilage surface is in good condition. So this is the type of patient who'll do well with the surgery and is very happy after we're done. Okay, so moving on with our knee series here. This is a 63-year-old patient. Again, I'm going to call this patient relatively young. And skiing, fell, heard multiple pops in her knee, which always makes you think about ACLs. She was able to ski down with an ACL. It's kind of difficult, but once she got down, she was clearly done. And when she came to see me in the office a couple of weeks later, she's got minimal pain. Her swelling, which was immediate, has gone down. She wore a brace, and really her main symptom is instability. So less pain and more instability. And when we talk to her, she's a very active 63-year-old. She loves to hike. She lives up in the mountains, and really needs to have her knee for all these activities. So physical exam is unremarkable, but very clearly when we do a ligament exam, she has a 2B Lockman and a positive pivot shift. So no surprises here when we look at her x-rays. She's got a decent looking knee, some narrowing, something you'd totally expect for a 63-year-old, of course. But she has an ACL tear, and the MRI shows us that the meniscus and the other structures are intact. So we go through our considerations again. Older patient, but physiologically actually somewhat younger, right? She's very active, not overweight, good alignment, knees in reasonable condition. Her activity level is high. Her general health is good. And what are her symptoms? Is she complaining about pain a lot? Because that's a different that's a different algorithm to someone who's complaining about instability. So, given what we've talked about, what are we going to suggest for this patient? Okay, so 29% versus 30%, pretty close there. But there's a distinct interest in doing ACL surgery overall compared to conservative management. I think this one, everyone's right here. And this brings out some of the difficulty of what we're looking at. So it's obviously difficult when I'm just presenting some select facts to go into what we do on what patient. But, in this patient, you certainly could try physical therapy in an ACL brace. I think that's a reasonable choice. She's very active, and so would probably not do as well with this as someone who said to you, well, I'm 63, I've decided to hang up my boots, I'm not going to do skiing anymore, I just want to play golf and tennis. If that's what they're telling you, I would probably lean heavily towards physical therapy in the ACL brace. But as presented, we talked about that she wants to stay active. Her main symptom is not pain, it's instability. And so I think surgery is a good choice for her. I put this up here because we really have some strong data now showing that younger patients, and the cutoff for that is probably 30. Some people use 35, some use 25. But patients younger than whatever number you want to use don't do as well with allograft. They have a much higher failure rate with allograft. So in younger patients, we tend to use autograft. But in older patients like this, it's probably not going to make too much of a difference. And this patient actually underwent an allograft ACL reconstruction, did well, and is back skiing and doing everything she wants to do. And the point here is that we oftentimes think of the older patients, and that age has gone up to 40 to 50 now, steadily climbing. But that older patients, we don't tend to want to do ACL reconstruction surgery. There is some definite negatives to doing ACL reconstructions in patients who have arthritis. But in the select patient that is older, that has a younger looking knee, that does not have a lot of arthritis, whose main problem is instability, not pain, it's a good surgery and is something that really yields good enough results, good as you would find in a younger patient as well. So this is very clearly a case that really is the guiding principle of all surgery, which is patient selection. If you select the right patient and really are not operating on just everybody that comes in the door, you're going to get good results and have happy patients. Okay, so more knees. 53 years old. Okay, so I guess that used to be called middle-aged. I'm still calling that young. Prior injury, no prior injury. Was getting up from a squatting position, felt a distinct pop in the knee, and had some swelling and the pain, and this was about a month ago. But this patient's not super healthy, has type 2 diabetes, has hypertension, and is somewhat overweight. BMI is 30. You examine them, now it's a month later, there's still a mild effusion, the range of motion is a little limited, it's about 125 on the other side. There's some diffuse tenderness medially and posteriorly, but overall the rest of their knee looks pretty good, their alignment is good, their stability is good. And this is what their x-rays look like. You know, decent joint space, alignment looks reasonable on these films. So what's your next step here in this patient? It's someone who's had an injury, they've got some swelling, it's, you know, subacute, it's a month later. They're not a very active person to start with. So what are we going to do next? I mean, very conservative treatment, a little bit more aggressive, more imaging to get you more information. What are we looking at? Okay, so non-weight bearing, anti-inflammatories, conservative management. Throw in some PT as well, probably the most of you. The injections and PT as well, most of you. And then imaging. A small section of people would go to imaging. And I think that, you know, we've got a patient who's had an injury, it's not a very specific injury. We would all tend to think about conservative management in this case. But the reason I'm obviously showing this case is there's something a little bit different about it. And in this case, we would actually go to an MRI. And the MRI shows a medial meniscus tear, and I'm going to go back and explain why. But we would go directly to an MRI in this patient. And this is the tear that's shown up on this MRI. You don't see the tear on this coronal image here, but what you can see is the medial meniscus, and it's sitting a little bit outside of the joint. It's not sitting in the joint where it should be. It's kind of extruded, right? That's what we'd call it, an extruded meniscus. And when you look at the posterior horn of that medial meniscus, there's a gap there where it's supposed to attach right at the root, right? This is the root of the meniscus, and there should be an attachment here. So this is a root tear. You can also see on the sagittal that where you should see a thick black triangle, you've got this sort of look to it that's kind of like it should be there. It's like a ghost of what it should be, and we actually call this the ghost sign. This is, you know, a missing meniscus. And sometimes if you get lucky on your axial cuts, you'll actually see, here's your medial meniscus, and then there's this gap right here. So this is a variant of a medial meniscus tear that we've recognized in the last 10 years or so as a root tear. And prior to that, we had very little understanding of exactly what this meant. So knowing that this is a root tear, what would you recommend here? Are we going to continue with physical therapy? We could put this patient in an unloaded brace, or are we going to go straight to surgery? And then what do we do with surgery? Is this a lost case and we're going to go straight to a knee replacement, or is there something else that we can do? All right, so most of you want to repair this, but this is an older patient. You know, some of these patients, I have some of these patients whose BMIs are 30, 35. Are there any other orthopedic surgeons in the room? I can admit that I've done a patient whose BMI is 45. So it's not your typical young athlete meniscus repair. And I'll tell you that probably hundreds or maybe even thousands of patients, before we recognized what this entity was, got partial meniscectomies, which is an essentially useless surgery for this type of condition. The correct answer, as we're finding out more and more, is actually surgical repair, something called a root repair. In those cases where there's a fair amount of arthritis already, you might consider going straight to a partial knee replacement if the patient has significant limitations and is really not doing well. fixing that fixing that meniscus root in those patients sometimes is just not going to work, and you can go to a partial knee replacement. But I think the majority of this would be something we would treat surgically and try and repair. And this is what they look like. There's a clear gap here. This is the meniscus coming in here. Should attach right here. You should not see this gap. And this is, again, the tear at surgery. This is the meniscus coming along here. You can see, these are older patients. They have some arthritis. That's not a perfect-looking condyle or tibia here, but this is a tear. And what we're really dealing with is once that meniscus root is torn, it's a functional meniscectomy. It's like taking out your meniscus, which is what we used to do in the 50s and 60s, is take out the meniscus if it was a problem. We knew that all those patients ended up getting getting arthritis young. So we now have very good biomechanical data that shows that making that root, fixing that root will actually restore the biomechanics of the knee. The clinical data is coming along, and there are studies like this that show that if you do repair that root, this is what that repair looks like. You take stitches down there and you put it through into a tunnel, that you get decent results at 5 years. This is an example of doing a partial meniscectomy for a root repair, for a root tear. Here's what it looks like initially when the root tears. This is a few years later. That knee is not salvageable. It goes on to a total knee. This is what we're finding in some studies now, 7 years later, that medial meniscus is holding up and still providing the joint with good biomechanics and saving that patient from a knee replacement. So the take-home point, really going back to our presentation on the initial presentation of this patient, is you've got to have a high index of suspicion. These are usually older patients, i.e. the classic would be a 50, 55, oftentimes overweight, oftentimes some early degenerative changes in the knee. And it's usually a hyperflexion or getting up from a squat or a relatively minimal amount of trauma and a sudden change to a significant, my knee used to ache every now and then it just really hurt a lot. I felt it pop and there was a lot of swelling. Those patients have a little extra suspicion in your head that they maybe have a root tear and maybe go to an MRI sooner. Certainly your average, just sort of my knee started hurting more, you would go with those conservative things. But I think the sooner we get to these, the better. So think about an MRI for those patients. All right, so let's switch to shoulder and look at a couple of things that we see very commonly. 49-year-old, this is a patient who swam competitively in college, still likes to swim, but has had progressive shoulder pain for 6 months, no specific trauma, but it does limit his swimming. His examination shows a little bit of limitation in his range of motion. Impingement tests are positive. Rotator cuff strength is normal, does report some pain with testing. Labral tests are equivocal. There's non-tender over the AC joint, and there's a little bit of pain with the cross-arm test. X-rays, joint space, no, not bad at all. AC joint looks a bit narrowed, and your MRI is showing that there's labral changes here with what the radiologist would report as a labral tear. There's rotator cuff tendinosis, not a frank tear, but maybe some partial tears. And here's his AC joint. It's got some cysts. It's clearly not happy. So, this is a patient that comes in with shoulder pain, but there's a lot showing up on that MRI report that the radiologist sends you. Are you worried about the rotator? As always, right? They can't ever report a normal case. There's every 54-year-old has at least 3 pathologies in there, even if they're asymptomatic. So are we worried about this guy's rotator cuff, his labrum, his AC joint? What can we do to figure out what's going on here? What's our next step? Okay, physical therapy. Cortisone injection. PRP and surgery. No one wants to go to surgery. Jeez. So, we're looking at a scenario we see very commonly, right? There's changes on the MRI. MRIs are very sensitive, and they are not actually helping us. They're confusing us more than anything else. So I think that this is very clearly one we would all really start with physical therapy. The cortisone injection I actually think is a good choice. I usually let my patients direct me as to their frustration level with these cases. So I'm really frustrated. I want to get this fixed as soon as possible. What can we do? Well, those ones I might lean more to doing an earlier cortisone injection. Others I usually say, let's do some physical therapy, see how that goes. We can try an injection later. PRP for this particular indication, I think that's an appropriate number. We don't have any data to show that it works for this situation. I think we're going to find that there may be some place for it, but right now I don't think the data supports that. And I think surgery is probably aggressive for this situation. We look at rotator cuff tears, a big tear like that, okay, that's a structural problem. We probably need to fix that. We'll talk a little bit more about in who. But, cuff tears are very common. They affect the older patients. And, these studies that have been done about asymptomatic patients getting MRIs showing tears of 51% in the older patients, 30%. These MRIs are really sensitive, and they're picking up a lot of pathology that we have to very carefully sift through to be sure that we're actually getting what we want for our patients. And these atraumatic degenerative rotator cuff tears really are sort of a mainstay of what we see in our offices. And I think that we really just want to say conservative treatment first for sure. Some of them will end up needing surgery, but certainly not the majority. There's been plenty of studies that show that physical therapy is very effective for this. 75% or so of patients will do as well with physical therapy as they do with surgery. So certainly want to consider conservative management for these sort of degenerative, non-traumatic type tears. What about this 53-year-old patient, not very active, does some work remodeling bathrooms, so he is actually a laborer of some sort, but decided to try a hoverboard for the first time. Great orthopedically devised instrument for orthopedic injuries. He's not the super healthy guy, got a lot of issues with high blood pressure, and he's a smoker, and his examination shows clear weakness in the supraspinatus and infraspinatus, limited range of motion. He's neurovascularly intact. This is his MRI, okay? So this is his supraspinatus, comes along here, comes to a sudden stop where it's supposed to end over here on the end plate, and there's a fluid-filled gap there. So this is an acute cuff tear in a patient that has otherwise not had a problem in the shoulder before. So what are our choices here? Next steps. All right. So a lot of you want to go to physical therapy on this patient. And I think that, again, talking about rotator cuff tears, that's always a decent option. It might be the type of thing you would consider in this patient if they were very much against surgery, or there was a problem with their medical condition that you might want to avoid surgery. But this is a different entity to our degenerative tears. This is a traumatic, sudden change from a patient who's able to lift their arms up with no problem to suddenly coming in with this, hey, something's wrong. I've got a broken wing. And these ones we tend to be far more aggressive surgically. And this is a patient who we would take to surgery. I think that's the correct answer. The results of those patients with acute full thickness tears, especially with retraction, that don't get surgery are not as good as those that get surgery. And in fact, the worst the case is if you have a massive tear where the infraspinatus, the supraspinatus, and the subscap has been torn off acutely, if you don't get that patient into surgery, they are going to have significant problem. They're not going to do that well with physical therapy. With surgery, they actually have a very decent chance of getting back most, if not all, of their function. So we treat the degenerative, non-traumatic tears very conservatively. We treat the traumatic, clear new finding tears far more aggressively. The take-home is really, what I've said. They're common. They're very common in older patient, and most times not surgical. But acute cuff tears is something we look at very differently, kind of like the root tears in the meniscus. Most meniscus treatment is conservative. There are specific areas where we want to be more aggressive early on, and that's the acute rotator cuff tear. What about the labrum in this guy? He's he had changes on his MRIs. I don't know how many times I see labral changes on the MRI reports on any patient that's had an MRI. It's very frequent, and we don't ignore it, but we definitely take it with a pinch of salt when we see labral changes reported on the MRI. And even, we look at them and we see them and we can see those changes, but it's part of the normal degenerative process. If you have that young pitcher that is coming in and they've got an MRI with a labral tear, we can talk about, that's a whole separate lesion, the SLAP lesion problem. But if you have, like this last patient, that first shoulder patient, a 49-year-old that has labral changes, it's seldom that is the problem. So we don't ignore it, but we definitely look for other problems first before we really think that the labrum is the issue. So we got a little bit more time. I'm going to go. This will be our last case. Instability. 26-year-old dislocated his shoulder 10 years ago. He was 16 when he first dislocated it. And he didn't have surgery, did well, but then recently had a obviously traumatic injury falling while hiking, landed on an outstretched arm, clearly dislocated his shoulder, got relocated, and he's come back in, and he's doing okay, quote unquote. Exam, you show he's got good range of motion. There is some pain with rotator cuff testing, and his instability signs are positive, right? Apprehension and relocation, and you can actually physically translate him. This is the X-ray, normal-looking joint. There's a little lesion down here, but I don't think that's of any significant relevance. You get an MRI on this patient, find the Bankart lesion, the glenoid bone is in good condition, and there's a small Hill-Sachs lesion, which you could actually see right there. So, our considerations. Age. Now, that's age at the time of this dislocation and age at the time of first dislocation, also very important. The nature of the injury, was it traumatic, or was he able to just pop it in and out by himself? What are the symptoms? Is it instability or is it pain? And what does the imaging show? So what are we going to do for this patient? Put him in a sling and immobilize him for a while, send him to physical therapy, cortisone injection to help control the pain, or do we go straight to surgery on this patient? Okay, surgery, good number of you pushing for that. Physical therapy, conservative management, also a decent number. So what is sort of the main concern here? It's obviously the redislocation risk. And we know that if you dislocate in your teens, you have a very high, 90% or so, likelihood of dislocating again, and that surgery is probably a good idea the second time around. This patient dislocated at 16, actually did well and redislocated at 26. So I actually think there is a place for attempting conservative management here. I couldn't argue with someone who said we're going to try that first. I think that the data would show that there is still a very high risk for another dislocation. But, an arthroscopic Bankart, not even an open one, does require a lengthy recovery. And so you might want to think about a conservative approach in this patient. I think the standard answer would probably be surgery, and that would be correct, but this is one where there's a little bit of a gray area. And the reality is that most cases, if it's a young patient, we're looking at conservative management for the first time. And then if they recur, if they have another dislocation, we're going to do surgery for them. And if we have those patients that are multiply dislocating, now what we're doing is far more extensive stabilization procedures. But the take home here is the young patient has a very high dislocation rate, so we've got to consider surgery for those. And in fact, there are some orthopedists around the country that are actually promoting first-time dislocators surgery right off the bat. And, there's good data behind that. So I think that we just need to be a little bit selective as usual. Again, patient selection is everything. I think when we look at surgery, it's not always as straightforward. We have algorithms, but we have to tailor that very well to the patient. Frequently, we're going to go with conservative management, but there are some conditions that we are red flags for, hey, this one will probably do better with surgery. And with that, this was for the wet weather, but apparently it's nice and dry today, so that's great. But we're prepared. Thank you to everybody, and I'm happy to answer questions for a bit over time.